So just a couple of words about HCA Virginia. We're a healthcare provider with a significant footprint across Virginia. We operate 13 hospitals, numerous outpatient facilities, work with thousands of physicians across the state with concentrations in the Southwest Virginia market in the Roanoke Valley, Northern Virginia, Central Virginia, and Fredericksburg. But I think what is also important to remember is that this is an employer-based conference. It's appropriate that the Chamber of Commerce is hosting us, and that HCA Virginia is also the 5th largest private employer in the state of Virginia. We have nearly 15,000 employees across the state of Virginia. We have a payroll of $685 million across the state of Virginia. We delivered uncompensated care of $650 million across the state, and we pay over $70 million in taxes. And when we talk to employers that are concerned about their health care costs and the challenges going forward, we understand that because we provide health insurance benefits for over 30,000 employees and their dependents at an annual spend of nearly $78 million. So we get it on the provider side, but we also understand it deeply on the employer side. So we're talking about payment and delivery reform. And so delivery reform in a piece is really about how we create value within the system. So if you believe that value is defined as quality divided by cost, we would actually define it as quality and patient experience divided by cost. You have to have high quality if you're going to drive high value. So Virginia actually does pretty well. Lynn Nichols showed some data earlier today that healthcare costs relative to the rest of the nation are a little better than average. But what I want to show in this slide is how does Virginia perform on quality? And this is just a composite score for core measure performance, which is a metrics that are publicly available on the CMS website. And they're just pretty basic measures of what kind of care do we give patients across the state that are having heart attacks, come in with pneumonia, have heart failure, or having surgery. So the national average is on the far right of the slide. Virginia scores much better. We are very proud at HCA that we actually best the state average, and that we believe that one of the ways that we're going to create value is through a relentless focus on quality. Delivery reform also talks about some things that Lynn Nichols just talked about, and that's big data. So this is a study from the New England Journal that was published last week. And why am I showing this article? Because it's a really important article. HCA took 75,000 patients in their hospitals, 43 hospitals across the state, and performed a pivotal study on how do you reduce ICU infections. So right now in many hospitals around the country, in fact every hospital, you have to do active surveillance for MRSA infections in the ICU and then try to figure out who you have to treat, who do you have to prophylax, and who do you not. HCA did probably the largest study of its type ever, did it very quickly in partnership with the CDC and Harvard, and basically showed that if you just wash patients with chlorhexidine washcloths and use mupirocin, you can drive infection rates down in your intensive care unit. You can reduce MRSA clinical infections by 37%. You can reduce bloodstream infections by 44%. This is a really big deal. 250,000 MRSA infections in this country every year. And so if you can reduce those by 37% and bloodstream infections by 44%, think of the human suffering that is avoided and the costs that are saved. So boy, does this fit in with what the triple aim is trying to deliver? So we took a lot of hospitals, and one other really important point. This is real world data. Hospitals in Virginia participated in this study. Our hospitals in Pulaski and Lowmore, Virginia, Blacksburg, Virginia, Salem, Virginia, and Richmond, Virginia. So one of the knocks on academic research is that it happens too much in the academic medical center. Let me tell you, it does not get more real world than Pulaski, Virginia, or Lowmore, Virginia, or Richmond, Virginia. All shapes and sizes of patients, all kinds of populations. So this is the utility of what Lynn was talking about earlier by using big data And this type of effort is going to be pivotal going forward to realize higher quality at a lower cost. I should also mention, actually, if I can back this up, Virginia's well represented on this slide. John Perlin, who's the Chief Medical Officer for HCA, trained at VCU, has deep Virginia roots, went to the University of Virginia, spearheaded the study on behalf of HCA. But also, more importantly, there was an accompanying editorial, lead editorial in the New England Journal, and it was written by Dick Wenzel and Mike Edmond at VCU. So there's enormous intellectual capital within this state to help drive the transformation that we need. At HCA, we've been spending a lot of time with employers trying to understand ourselves and our problems more deeply, but also what's the employer community undergoing and what are they thinking about, what's on their mind. One of the key things that we've learned is it's a lot about access. So a consistent theme is, what can employers ask us, what can we do to help create access for our employees to spend time to get to the primary care doctor, and how can you help us build a primary care relationship? They're aware that they're very worried about chronic diseases. They know that there's a minority of patients that drive the majority of their cost, and how can we help them address those? And lastly, the cost question, and how can it not be on everybody's mind? One thing we've done in the Central Virginia marketplace is that we have formed Virginia Quality Care Partners in partnership with over 900 physicians in the Central Virginia area. We have formed a clinically integrated network, which is a pretty specific term, where doctors come together in partnership with a health system, and we develop a quality program. And this is really physician-led and physician-managed. And how do we start the conversation about doctors holding themselves accountable to a clinical quality program? You've got to have a lot of IT infrastructure for this, but I think that this is starting to change the conversation in the physician community and the provider community. We enrolled 16,000 covered lives out of our employee base in Richmond and Central Virginia into the network beginning January of this year. It's embedded in all 3 of the HCA benefit plans. The patients have very significant incentives to utilize doctors within the network. Our employees, if they see a doctor that's in the network, have a $15 copay, and they have a waived deductible. So significant economic incentive to see our doctors who are going to submit quality metrics on the care that these patients deliver. So it really is a game changer. At the same time, we are actively trying to understand our employee population and our employees' health problems on a much deeper detail. So we're just really getting into this in the first stages, but already we can see that 10% of our employees drive 70% of our cost. And if you look at the bottom right-hand corner, you'll see that certain conditions predominate: heart failure, COPD, diabetes, morbid obesity, asthma. Does that sound familiar to you all? What surprises us is that usually it's maybe 20 and 80. We're 10 and 70. But what I think is the opportunity is that if you look at the numbers of patients in the right-hand corner, we don't have to really focus on 15,000. We have to have certainly benefit and care and respect for those employees and make sure that they have access to primary care. But if we just really can start to focus our attention on those smaller population of patients, we can do a couple of things. We can make their lives a lot better. We can reduce the amount of pain and suffering they have to go through. We can help them to be more productive at work and have better time with their family. And you know what? We'll reduce costs at the same time. So I think we're starting to see the bridge of opportunity going forward. Our next phase of this is to continue the dialogue with employers. As Lynn said, employers have got to have the data, and we are intent on developing the capabilities that we can look at an employer's data, we can share the data, we can tailor care management strategies for your population of patients, and through that we will realize the aim of better quality and lower costs, and almost as importantly, increased productivity when they're at work. So I'll end with this slide. This is the new Huguenot Bridge over the James River a little bit west of here, and it's very close to where I live. There was a very old and rickety bridge that you used to have to drive across. It was very thrilling by the end, and with the recent bridge collapse, I'm really glad this new bridge is open. But you know what? It took a long time to build this bridge. And so they had to build some pillars for the new bridge, and then they had to start tearing the old bridge down. Then they would build the new bridge a little more, then they would tear more pieces of the old bridge down. And that's what we're getting ready to have to do. We've got to build new pillars, we've got to build new bridges, but we're going to have to tear some old structures and old ways of thinking down, and it's going to take time. This is not going to happen nearly as quickly as we would all like, because at the same time we're doing all this construction, the hospital has to be open and the emergency room has to be open 24 hours a day, 7 days a week. If you're in the doctor's office, Mrs. Jones is calling in sick this morning and has to be addressed today. So we've got to do all this work in real time, no easy feat. But I hope what I've left you with is that we're thinking a lot more about data and data transparency. And I couldn't agree with Lynn more. The employer needs to understand the situation in a much more deep manner. We've got to work with our physicians, because what it means to be a physician is changing right in front of our eyes, and that there has to be more responsibility for professional performance improvement. And we've got to develop innovative models on quality and cost and how we get paid and how we align incentives go forward. And at HCA, we look very much forward to exploring this with the business community.